Hello, I'm Dr. Richard Morse from Pediatric Neurology at Dartmouth Hitchcock Medical Center, and I've been asked to talk today a bit about autism and epilepsy. I thought I would put it in the context of epilepsy as a separate entity and then autism as a comorbidity of epilepsy to frame my talk and keep my comments limited to that. In general, you all know what epilepsy is. It's defined simply as recurrent, unprovoked seizures. A seizure itself being defined as excessive neuronal hypersynchrony in the central nervous system, in the brain in this case, resulting in an abnormal involuntary event in the patient. The factors that go into seizures are pretty well known, most seizures being provoked events. But the factors that play into epilepsy and epileptogenesis, which is the creation of the epileptic brain, are a little less well understood, but have great bearing when you talk about autism and epilepsy, because they probably share somewhat common pathophysiological mechanisms in terms of what would create the autistic or create the epileptic brain and why they co-occur so often. In terms of epilepsy and seizures, there are classification schemes for them that I'm sure you're well familiar with, but just to review them briefly, seizures are classified according to whether they affect part or all of the person, so they're partial or generalized. The partial seizures are further subdivided into simple partial, when only one part of the person is affected and their mental status remains unaffected, so they can be fully alert during the seizure, and complex partial, in which there is impairment of consciousness as well as a simple partial seizure. Either a simple partial or complex partial can secondarily generalize. The generalized seizures are affecting the entire person and span from generalized tonic-clonic, myoclonic, clonic, all the way to absence, which is a staring spell behavioral arrest type seizure, but is also considered generalized with impairment of consciousness. The EEG characteristics of many of the seizure types are well known, and when you add EEG characteristics to a seizure type, you begin to talk about an epilepsy, which again is recurrent unprovoked seizures. The epilepsies in turn are classified according to whether they are primary generalized, and most of those are genetically based, or symptomatic acquired epilepsies, which can result from various insults to the nervous system, developing nervous system malformations, infections, trauma. Within the area of autism, which is a very common condition, epilepsy being about 1 to 2% of the population, autism and autistic spectrum disorders being about 1 to 2% of the population, both of them being very common conditions. Within the autistic spectrum disorders, and I'll leave it to Dr. Mott to define autism because that's one sticking point that I'll mention in a minute. Within the autistic spectrum disorders, there are about anywhere from 20 to 60% of people described as having epilepsy. So it's a very common comorbid condition. Trying to tease out who within autism has epilepsy is a challenge. Sometimes it's obvious because clinical seizures are evident and they are like everyone else's clinical seizures. There's no one type of epilepsy that characterizes autism, and that probably results from the fact that what defines autism is a heterogeneous group of individuals. There's no one biomarker, one blood test, one way to say you have autism. It's a clinical diagnosis largely. Epilepsy is somewhat much the same in that we don't have a blood test to say you have epilepsy. We have a limited number of genes that we can test that say you have this kind of epilepsy. Those aren't relevant to discussion of epilepsy in autism, in that most of the children who have autistic spectrum disorders and epilepsy don't have and share a single epilepsy or seizure type. You can see any kind of seizure and any kind of epilepsy within autistic spectrum disorders. But overall, they are at increased risk, and it ranges about 50%, you could say, would be a good working number of children with autism are suspected of having epilepsy at one point or another in their lives. When you drill it down a little bit closer, the overlap of autism, epilepsy, and intellectual disabilities becomes really important, in that the children with autistic spectrum disorder who also have intellectual disabilities are at very high increased risk for having epilepsy. The children with autistic spectrum disorder who don't have intellectual disability, who are normal on IQ testing, which is often a challenge to do in young children, are at about the same, if not a little higher risk for seizures and epilepsy than the general population. It's still higher, but it's not massively higher. If you add in intellectual disabilities, the numbers jump way up into the 30, 40, 50% range. So that immediately identifies on a practical level a group of patients who you might be thinking, okay, I've got to think about epilepsy in this group because the risks are really high. So your children with autistic spectrum disorder who have intellectual disability as well. Again, the challenge in determining intellectual disability, autism, the combination of them is not small, and it's certainly still a difficulty to always be able to confidently say this patient has intellectual disability versus autism versus both. But I think that in terms of trying to sort out risk factors and say who should I work up and look at a little closer, those who have intellectual disabilities are an overlapping group that may, again, share a common pathophysiology. The epilepsy number of children who have intellectual disability is much lower than those with autistic spectrum disorder, but it's still a considerable number, about 20 to 25% of children with epilepsy, mostly the severe end of the spectrum, many of them represented by the severe age-dependent epileptic encephalopathies of childhood, which are known as West syndrome, Lennox-Gastaut syndrome, Dravet syndrome, Fragile X, and some of the other Rett syndrome that are highly associated with epilepsy and intellectual disabilities. But in general, many of the other genetic epilepsies are not associated with intellectual disability. So it's a common link between the two entities, and any child with autistic spectrum disorder and intellectual disability should be looked at very closely for the high risk of underlying epilepsy or the possible occurrence of seizures. It gets a little more complicated than that because about 60% of children with autistic spectrum disorder have been reported as having abnormal EEGs, epileptiform abnormalities on an EEG. When we do an EEG, we're looking for sharp waves or spikes. These are called epileptiform abnormalities, and they aren't supposed to be there. In the general population, maybe 6 to 7% of children will have an epileptiform abnormality on their EEG, no history of seizures, no clinical significance to that finding. In the autistic spectrum disorder crowd, it's up to 60%. And again, there are a certain number of those children who will never have had a seizure, and we don't know what the meaning of that abnormal finding on their EEG is, and whether it has clinical significance or not. There are plenty of other models of epilepsy and spikes on EEG, or spikes on EEG without seizures, in which children have cognitive impairment, learning problems, even regression in their development without having had a seizure, but with having an abnormal EEG. And those are special types of epileptic syndromes known as epileptic encephalopathies, usually limited to children, and associated with up to severe effects on their learning profile and their cognitive performance. There have been lots of studies showing that a single spike on an EEG does impair your performance for a second or two after it occurs. So when you find spikes on an EEG on a child with autistic spectrum disorder, it's a natural question, and one that is still unanswered. What do you do about it? Do you treat it? What does treatment do? Is it helpful? Is it worthwhile? Should it be being done? And much of that's understudy, and much of it's understudied, in that we haven't really had good multi-center, well-designed studies to look at whether intervention makes a difference or not in cognitive outcome. In some of the non-autistic spectrum disorder underlying abnormal EEG epileptiforms, treatment can help. So there is this spark of interest in saying, well, perhaps if we did chase spikes, chase abnormal EEGs, and treat them, that in some cases it might make a difference. And I think in some cases it has for children with autistic spectrum disorder. We just don't know enough yet to know who and in every circumstance whether that treatment will help. That's a part for long-term clinical research that still is waiting to happen. So I think in general that the final part I'll talk about is the definition of autism and autistic spectrum disorders. DSM-5 is about to come out with a new comprehensive definition that puts together many of the old categories of PDD, not otherwise specified, and Asperger's. And I think that, though perhaps a step in the right direction, still needs to be looked at as case ascertainment and who it is that you're defining as autistic and how you're defining them as autistic. It's still a clinical impression. It's still a expertise matter to say who has autism and where along the spectrum they are. And I think that that confounds almost all studies on the occurrence of epilepsy, autism, and the best treatment and treatment approach. In today's day and age, I would say that having a low threshold for doing an EEG on a child with autism or autistic spectrum disorder to look for occult underlying epileptiform abnormalities and considering treating them makes a lot of sense, because the seizure types can be easily missed and overlooked in kids who have autistic spectrum disorder, who may hand flap, who may stare, who may have odd sensory responses to things that may mimic a seizure and on the one hand be innocent. On the other hand, they may be actually seizures or representing a seizure, and until you do an EEG, you really don't know. I think that the question of how long an EEG, what kind of EEG, is again up for grabs somewhat. I would say I try to triage it by saying, what's the risk factors and how much at risk is the child? What's their clinical profile? What's their clinical history? And if they are certainly not doing well, regressing, if there are suspected seizures, if there's any sense that there might be something you could do to help them, in addition to the therapies and the applied behavioral approach that should be done as well, then I think it's important to look at an EEG and look into the crevices of deep sleep so that you really know that you've looked thoroughly at these children.
I'm Dr. Stephen Mott. I'm also part of the section of Pediatric Neurology here at Dartmouth Hitchcock Medical Center, and I'm a developmental cognitive neurologist, so I'm both a neurodevelopmentalist as well as a pediatric neurologist. So I've been asked to also comment on autism and epilepsy. And briefly, autism under the new DSM-5 is a primary social interactive impaired child with communication and language impairment, particularly regarding social interaction, as well as a second criteria of abnormal restricted repetitive behaviors. Rather than the prior DSM-4, which divided it into three parts, which was social interaction, communication or language, and the restricted repetitive behaviors. By combining both social interaction and communication into one category, if there's just positivity in that area without restricted repetitive behaviors, we call that a social communication disorder, which is somewhat like the previous PDD-NOS. The major changes with the DSM-5 are first identifying that this is a primary social interactive communication disorder, meaning not secondary to ADHD, schizophrenia, language disorders, where we do have social interactive impairments, but they're secondary to those conditions, just to name a few. The second aspect of the DSM-5 is to look at the degree of language impairment within the communication. Are they impaired in terms of their expressive and receptive language, or is it solely their pragmatic or social interactive language, which was the area that was only impaired in children previously diagnosed with Asperger's, for example? Whereas in the prior DSM-4, those that were high-functioning autism also had impaired expressive and or receptive language. The incidence of restricted repetitive behaviors is extremely common and is necessary to consider within the autism spectrum. When we talk about epilepsy in the autism spectrum, it's extremely important to understand that studies that have looked at adults that have autism, 25% are on anti-epileptic medications to treat epilepsy. They may be on more, or there may be more of them that are on anticonvulsant medicine that are being used for mood stabilization and for other reasons, such as and aggression. But 25% are being treated for epilepsy. 60%, as Dr. Morse has indicated, have abnormal EEGs that may or may not manifest themselves as having true clinical seizures. Therefore, in my estimation, we are missing a whole lot of these kids before they become adults and are treated. And that is because of this the second category of restricted behaviors. Studies have looked at what constitutes a reason for doing an EEG in a child, as well as in a child with epilepsy. It's clear that if they have any of the motoric changes that we see, sudden stiffening or clonic movements where they have jerking of their arms and legs and eyes rolling up, these are very obvious. But that's really not where our controversy is. Our controversy is in these restricted repetitive behaviors. They may have hand flapping, they may have sudden tensing and staring that may last anywhere from 5 to 15 seconds. These are the times that we need to be concerned. The other comment that's frequently made about children with autism is they are lost in their own world. Well, are they lost in their own world and truly disconnected? One way that I have families differentiate this, and I actually have their teachers and therapists do this, which is take one's finger and rather than call out the child's name, rather than wave your hands in front of their face, take that finger and come at them from the front and touch them in the nose. Most children, you come at them from the face, they're going to try to avoid. And all of them, once you touch their nose, will grimace in some fashion. If they remain stone cold, looking straight forward, unaffected, then that's when I am most concerned that this child really does require some workup for epilepsy with an EEG. So that's one. The other is the restricted repetitive behaviors that tend to be the same each and every time with sudden onset, whether they are followed by fatigue or not. I feel that these are cases that also need to be looked at closely to consider for epilepsy. Relative to the first diagnostic criteria in terms of language and communication and social interaction, studies have shown that 1/3 to 2/3 of these children show a regression, and a true autistic regression, which means that they've lost nonverbal communication as well as verbal communication. These are children that should undergo an EEG because there are certain syndromes. Although Landau-Kleffner syndrome has been talked about a lot, there's actually a very low incidence of true Landau-Kleffner syndrome in autism. Yet the characteristic of continuous spike wave or epileptic activity during sleep is not uncommon in autism and should consider certain treatments.
So I wanted to add a couple of random comments on after hearing Dr. Mott's presentation, and a couple of facts and things just to define some entities in epilepsy. One thing that I came across in reading about epilepsy and autism is that it's not at all uncommon. As a matter of fact, it's quite common for epilepsy to start at puberty with children in the autistic spectrum. So just because they don't have seizures when they're 3 or 4 years old, or they may have an abnormal EEG that is not felt to be clinically significant and not acted upon, doesn't mean they're out of the woods. So just to keep in mind that autism is a lifelong condition. Many epilepsies are outgrown, but autism generally, if it's diagnosed correctly, doesn't tend to be. So your teenagers and your adolescents with autism are another group to watch closely for the appearance of epilepsy, as it's apt to come on at that time. The other is just to sort of mention that Landau-Kleffner, which was brought up, is another term for that is acquired epileptic aphasia. So it's a communication disorder that is thought to result from underlying, usually occult, epilepsy. And when these kids get an EEG done, they'll have a constant spike wave discharge in the language area oftentimes that correlates with a clinical picture of them losing their ability to more understand language than express themselves. So there is a split that differentiates them from many children with developmental delay and language disorders, in that their receptive language tends to be more affected than their expressive, and they get a puzzling loss of ability to communicate over time. That obviously has a spectrum, but it's all lumped together into something called Landau-Kleffner syndrome. The other entity, which is another epileptic encephalopathy mentioned, was ESUS, electrical status epilepticus of sleep. It's a mouthful to say. And that's another very compelling childhood-limited disorder that we see in epilepsy, devastating in its effect, oftentimes associated with a regression, not just a loss of language, but often more prominent behavioral problems, autistic behavior spectrum as well. And that's an epileptic syndrome where when the child goes to sleep, and particularly in non-REM sleep stages, the EEG is characterized by continuous spike waves. There may be an occasional seizure, there may be no clinical seizures, but it is more often a developmental regression or behavioral regression syndrome. Hard to treat, often unsuccessfully treated, and speaks towards the very interesting opportunity we have to intervene in these kids, because sometimes left untreated, you can't, when the EEG resolves and gets normal, you can't make up for lost time, and the children's development will remain delayed and affected. So it's a very interesting area in pediatric epilepsy to know whether we can both identify it, because it takes a bit more of an EEG to identify it, and whether our treatment intervention can work. There's some children with autistic spectrum disorder who have electrical status epilepticus of sleep. The majority don't. So I just wanted to clarify that those are entities that are lurking around within epilepsy that overlap with autistic spectrum disorder and can mimic it as well. Another reason to consider an EEG if your child is older when they have their regression, older than the usual typical autistic regression, which is more in the toddlers. In terms of treatment and evidence for treating and whether treating an abnormal EEG makes a difference or not, there isn't yet much evidence to support it. It's not really been studied. There's no real evidence to not support it either. And it's just something that really needs a lot more study to clarify whether or not it will make a difference.
Yet there are a number of anecdotal reports of children that have autism that also have the abnormal EEGs who have been treated with anticonvulsants, who have shown quite significant changes, mainly in behavior, attention, and some aspects of their language. Again, the part of the brain that has the hyperexcitable activity that results in the seizure or alteration of awareness, cognitive impairment, is the area that should show the improvement when one puts a child on anticonvulsants. So one has to be very careful that they are monitoring what that improvement is. When I use anticonvulsants in these cases, I am making all attempts to be as objective as possible in terms of looking at these specific changes in children who otherwise don't manifest seizures.
And I think the treatment, which is, again, needs study. There needs to be much more standardized approaches with good endpoints and measurements. Most of the anti-seizure meds do not affect the spike behavior on an EEG. A few of them can. And so again, a carefully designed study would be important to look into it. And there are bits and pieces of studies going on around the country, certainly. But so far, it's still not to the point of standard of care or understood as evidence-based. On the other hand, all of us have seen lots of patients who you empirically put on an anti-seizure trial, anti-seizure medication trial, when they have an abnormal EEG and a clinical correlate of either cognitive delay or some sort of intellectual disability, behavioral problems, and seen remarkable improvement, turning around. And that certainly compels you to want to at least look into it and continue asking the question whether treatment's warranted or not.
We've seen this in patients that have cerebral palsy, for example, who haven't manifested a seizure but do show epileptic activity, either coming from one part or multiple parts of the brain, and seen improvement in their learning abilities. So it's not just autism that this occurs in.
And the other point I wanted to make is, and I think it's really important to stress, there's the pharmacological management, medication management, but with autism, with epilepsy, comprehensive management can't be ignored and has its very important role, so that the school, bringing the school into it, bringing the whole medical team into it, and the contributions that can be made from various resources in the community are just as important as the medication or the medication management. That's part of it, but I think out of context, out of a comprehensive approach, the comorbidities of epilepsy or the comorbidities of autistic spectrum disorder really can't be addressed without considering school programming, general community programming, family support and counseling, and all of those parts of it.
Absolutely. I couldn't agree more. The treatment for autism is education, education, and education. Matching a child's cognitive impairments with the appropriate school supports in terms of speech and language therapy, in terms of special education supports, cannot be met any better than through those specific therapies and a good, solid, individualized education plan. And medication is adjunctive. If a child has epilepsy, though, I feel that it's important to put them on anti-seizure medicines to allow for that continuum of social connectedness, that continuum of awareness, as opposed to having the lights click on and off. So I'm a real proponent for looking into the possibility of epilepsy. And the variation in practice in terms of performing EEGs is a subject that I'd like to discuss with Dr. Morse, which is what type of EEG should one do? Many of the children, it's very, very difficult just to apply the electrodes to the heads of these kids. And parents will tell me from the moment that I discuss the EEG, oh, what a horror show, and they'll never allow you to do that. And I state that, yes, it can be difficult. We happen to have a fine group of EEG technicians who work very quickly and are very patient with families, which is absolutely necessary. And it's very important for the family to bring in something that can distract the child, that they can concentrate on, which is one of the positives with children with autism, is they tend to over-focus on certain things. So when they do bring in that item and they are focusing on it, the EEG techs can put the electrodes on. But my feeling is if you're going to do this, and sometimes the child does need to be restrained to get these electrodes on, you might as well do the study that gives the best information or the most information. And that's why I have a preference to ordering the overnight video EEGs.
I was going to second the comment about treatment. Certainly if the patient has epilepsy or clinical seizures, no doubt the medication is warranted. And it's as effective in children with autism as in anyone else. So the epilepsy is easily, in most cases, easily and well addressed by medications. In terms of what type of EEG to order, I think that, again, I'm a little biased because I have had the experience with many patients that until you look in the crevices of deep sleep, you really don't see the whole picture. And there are plenty of patients, not autistic spectrum alone, but plenty of patients who have surprising findings on their EEG if you go through a whole night's worth of recording. I think that there's been an explosion of 24-hour EEGs now that we have digital EEG and we're not using up paper for every page of recording. They used to be really technically hard to do. The ink would run out and the machines would get tired. But in the digital age, we can really record for much longer times more easily. The hookup, the actual placement of the electrodes, barely differs from an outpatient ambulatory EEG. And so you do get a lot more information from a longer recording that includes sleep. In cases where there's a child who has communication problems and who is maybe declining in terms of their cognitive profile, I think it's even more critically important to make sure that you have looked for every possible treatable cause of their problem. To your satisfaction. I've had the, again, clinical experience where we'll do an outpatient screening EEG and happily say, okay, no epilepsy, no evidence for seizures. But you always have it in the back of your mind, well, did I miss something? Was it really there? And if the child doesn't get better or certainly continues to have problems, sooner or later you'll come back to asking that question. And knowing that there are perhaps windows of opportunity for development that may be absolutely related to the time in that child's life, I think it's important to not miss that in case your intervention does help. Because on the bright side, even though it's a small sliver of patients, there are plenty of people who have electrical status epilepticus of sleep or very severely sleep-related abnormal EEGs who, with treatment, improve dramatically and have really good outcomes. And so when you've seen that, you certainly don't want to miss it and consign a child to a lifetime of not knowing. So to summarize, autism and epilepsy are commonly co-occurring. There's a big overlap between them in that up to 60% of children with the autistic spectrum disorder will have abnormal EEG findings. Easily up to 40–50% will have epilepsy in their lifetime. Within the epilepsy number of patients, probably 8–10% will have autistic spectrum disorder features. So there's a big overlap between these very common conditions, and it's important to have a high level of suspicion in children who are at risk, certainly for epilepsy. And the children with autistic spectrum disorder and intellectual disability are the highest risk group, with numbers over 50%. So that would be the group to really look closely at in your practice and to refer with a low threshold for further evaluation.
The other group of children that we haven't talked about that should be referred for consideration of an EEG, whether they manifest epilepsy or not, are children that have autism but also have a secondary condition or a symptomatic condition such as Angelman syndrome or Down syndrome or tuberous sclerosis, where those entities themselves have an increased incidence of epilepsy. When you have the combination of the two, this is also an area that one should consider doing a prolonged video EEG.